So may I invite Professor Kianoush Kashani, and he has a very challenging title, I have to say, as an intensivist, refractory shock. So two difficult concepts to define, and well, he will he will discuss this definition.
Thank you very much for kind introduction. Thank you, Robbie, for invitation. This is great event, highlight of my year. I've had the privilege to be here for the last 20 years, and each time I learn more than I can contribute. Thank you very much for invitation. So I was tasked to kind of sell you the idea that it is good to have a definition, harmonized definition for refractory shock. So these are my disclosures. None of them is related to this activity. I don't get money from any of these. This is the outline of next 15 minutes. Now we'll start with the definition of shock. How do we define shock? In hemostasis status, there is a balance between oxygen delivery and demand. Often is maintained by appropriate perfusion and vasoconstriction or vasodilation appropriately in order to maintain oxygen delivery to tissues to the extent that they need. In shock state, there are two potential events. There is a significantly decline in oxygen support, or there is a significant increase in demand that would result in imbalance in this hemostasis status and would result in shock state. There are different types of shock. Distributive shock obviously is due to vasodilatory effect and capillary leak. Hypovolemic shock is when you have decreased effective blood volume, losing volume through internal like tear spacing or externally. Cardiogenic shock is pump failure due to arrhythmia or myocardial failure. Obstruction is when you have an obstruction in your cardiovascular circuit, including internally like intravascularly like PE or extravascularly like tamponade. And finally is dissociation shock when you have good other factors are appropriate, but cells are not able to use oxygen appropriately or oxygen is not delivered appropriately. So severe anemia when oxygen delivery is decreased, or toxicity with nitric oxide, toxicity with carbon monoxide or cyanide could result in shock state. So clinical and laboratory markers of shock, there are some common signs of all types of shock. One is altermentation because brain is so sensitive in requirement for oxygen. Decreased urine output, our beloved organ, is very sensitive in responding to that mismatch. Mottled skin, skin is the surface, is the largest organ that we have, and you can use it in order to assess perfusion. And also metabolism moves from aerobic to anaerobic, therefore production of lactic acid. This is an example of mottled skin score. This is a study of 60 patients, classified patients based on mottled score, kneecap versus knee versus beyond knee versus lower extremities versus the whole body. This goes from score 1 to 5, and these are examples of score 2 and 4. And we can easily assess that at the bedside. And importantly is that these scores are associated with higher mortality. You can compare score 0 to 1 to score 4 or 5, which 90% of those patients die. It would be a really great way to assess perfusion state. Interestingly, mottling score was associated with the declining urine output, increasing mottling score, in addition to increasing lactic acidosis. Increasing SOFA score, however, was not correlated with cardiac index. Means that mottling score is providing additional information to what cardiac index can provide you. So it would be a great tool. Now, how do we define sepsis? It's defined based on sepsis 3 criteria. We have this screening tool, quick SOFA, that we assess respiratory failure, and a little lower blood pressure, a little kind of altermentation. When patients pass quick SOFA, then we need to ascertain a presence or assumption of infection. And based on SOFA score, which I'll show you in the next slide, if patients make SOFA score of 2 and above, they have sepsis. And if patients with sepsis, they remain hypotensive despite fluid resuscitation requiring vasopressors and have signs of hypoperfusion, then they have septic shock. So this is so far score based on 6 organ failure, respiratory, coagulation, hepatobiliary, cardiovascular, CNS, and renal. And if each of these organs fail to the score of 2 and above, patients make criteria for sepsis. And if patients have less severity of organ failure, at least 2 of these organ failure with less severe failure can meet the criteria for sepsis. There are stages in sepsis septic shock management. First, we need to identify underlying source, assess cardiac output versus volume status to rule out other types of shock. Then we start with fluid resuscitation. If patients remain hypotensive, we add vasopressors. And then when following that, if patients remain hypotensive, then we add epinephrine versus vasopressin as a second line pressors or other pressors, including angiotensin II, looking into other possibilities, including using stress dose steroid. Among patients with low cardiac output, epinephrine may be preferred. Among patients with high cardiac output, vasopressin may be preferred. And then we decide in kind of patients that are sicker, decide to continue triple or quadruple vasopressor therapy. And there are some unproven rescue therapies that are used on patients that fail all of these interventions, including extracorporeal blood purification strategies, use of calcium infusion, methylene blue, and hydroxycobalamin, that there is no solid data behind it, but I have seen patients are being treated as a last resort that we potentially can have. It's important to know the vasopressors. There are some vasopressors that purely are vasoactive, including angiotensin II and phenylephrine and vasopressin. There are vasoactive vasoconstrictor, but do not have any impact on myocardium. Nitroprusside obviously is vasodilator. There are some inotropic agents like dobutamine that they have inotropic agent effect, and they are vasodilatory. And also there are some other pressors, including norepinephrine, that they have both inotropic effect and vasoconstriction. Now going to definition of refractory shock. Why do we need refractory shock definition? First of all, we need to kind of have that definition to identify patients victimized by refractory shock in order to assign more resources in order to provide additional treatment. We need to kind of have some diagnostic tools in order to be used solely on these refractory shock patients in order to identify the mechanism behind it and also the treatments possible. It can help us with prognostication for patients. We can talk with the families and start having care conferences. Guidelines could be standardized by having a solid definition for refractory shock. And finally, research. Research is, I think, is very important. I'll show you some definition of refractory shock in different studies that are completely heterogeneous. And therefore, results of those trials and studies cannot be compared with each other. Characteristics of an appropriate definition, we should probably define what is the minimum amount of fluid to reach the point that you can say that patient is fluid refractory. We need to define what is high-dose vasopressors that would help us to identify patients with refractory shock, including dose and duration. And also, what are the organ failure signs and markers that we can potentially use? And certainly, we need to kind of assess the subphenotyping of shock. These are different potential approaches to shock. The first category in green, there are shock with fluid refractory shocks that they receive an amount of fluid appropriately, but they are still hypotensive. They have a slightly higher mortality, slightly higher organ failure rate. The studies that can happen in these patients is that what is the first line vasopressors could be used. For example, what is the determinants of volume status that we can potentially use. The second group are those that are vasopressor refractory. So those that are more than 2 vasopressors, or they are more than a certain threshold for 1 vasopressor, could be potentially included in this category. They have higher mortality and organ failure. The studies on this group could be defining criteria, prognostic enrichment in phase 3 trials, and using new vasopressors. Those that now have refractory shock now start having organ failure, despite the best management with fluids and vasopressors, they have significantly higher mortality. These are patients that in ICUs, we start having care conferences with the families. We try to identify the goals of their management. The studies on these could focus on prognostic enrichment for the clinical trials using the questions about second line pressors, high-risk intervention trials, and subphenotyping. And finally, those patients that do not respond to anything. These are patients that, despite all the best management, they remain hypotensive, remain having progressive organ failure. They have very high mortality. Sometimes their mortality is too high to be enrolled in any clinical trial for research. However, rescue measures, as I outlined before, extracorporeal blood purification, use of ECMO, could be potentially studied in this patient population. Now, these are definitions that are providing literature for refractory shock. As you can see, some of them are observational, some of them trials, and they're all different. The yellow font indicates definitions that are focusing on the dose of vasopressors. The few of them, 4 of them with orange font, they also include organ failure into definition, but they are significantly different. Refractory septic shock is mostly defined as a dosage of individual or combined vasoactive medication required to achieve the blood pressure goals, not necessarily any other clinical impact. So to define refractory shock, we need to develop a concept as we are trying to do today, and we need to review literature as partly is done by SCCM. Then we need to have experts sit around the table, try to come up with the criteria that can define refractory shock and define it and then validate it. So these are stages that we need to take in order to have a reasonable criteria. I would like to present you a case example of successful shock classification that includes refractory shock. And I like this, and we have done several studies on this particular criteria. This is called SKY criteria. SKY criteria is Society of Cardiovascular Angiography and Intervention. This is designed shock strategy management for patients with cardiogenic shock, not necessarily septic shock. But I'll show you some data on this particular classification with sepsis. So patients at risk, majority of patients, there are those that do not have any shock, but they are high risk for shock. They just come in with huge myocardial infarction, or they had just rupture of papillary muscles, mitral valve failure. So they are high risk for shock state. And B stands for beginning. Those are patients that start showing some signs of shock, but they are not in full shock. Classic patients are those that are in shock. They need vasopressors. They have high lactic acid. They have organ failure. D are those with C class that now are deteriorating despite our best management. And E extremes are those patients that are about to die. They have very severe lactic acidosis, acidemia, and they have significant organ failure. They would not survive without mechanical cardiac support. Now, the criteria that are used are physical and bedside assessment, which we don't have it currently on sepsis data, apart from QSOFA. It's just some hemodynamic measures. I think that this is very important, partly subjective. However, that gut feeling of clinicians is extremely important, and has been shown over and over that sometimes clinicians are more accurate in comparison with mechanical data or other biomarkers. And this includes that in the definition, and also biochemical data and hemodynamics. So, for example, in group A, that they do not have shock coming with large myocardial infarction, physical examination is normal, lactic acid kidney function is normal, and then cardiac indexes are all normal range. In beginning patients, these are patients that start becoming hypotensive. They have slightly elevated JVD. They have a little bit of crackle in the lung. They still perfuse very well. They're warm and strong. Pulses are strong. However, they have some mild changes in their kidney function. BNP is elevated. And they are also kind of dropping their blood pressure. Cardiac index still okay, more than 2.2, but is declining quickly. In classic patients, you have patients in full shock, cardiogenic shock. As you know, these are unwell, panicked patients, breathing hardly. They have mottled skin, dusky skin. They have cold and clammy extremities. They have augmentation, urine output declines, and volume overload is what they are dealing with. Laboratory-wise, they have very high lactic level. Kidney function is quickly deteriorating. They have shock liver and increased BNP. Obviously, hemodynamic variables indicate that. Group D or Group C that now are deteriorating. This is the subjective part. and we have made a digital signature of this classification in our institution. Now we are using that for classifying patients. And finally, class E are those who really kind of are coding. They are on CPR, they need eCPR or mechanical treatment. Mortality in this classification increases from 0.6 in hospital to 90% based on classification. These are really clear in hospital mortality and 3-year mortality. As you can see, curves separate very quickly. Now, we try to identify SCAI relationship with acute kidney injury interaction in our CICU. 10,000 patients, 9,000 of them qualify for data. 51% had acute kidney injury. Among that, about 8% acute kidney injury stage 3. Half of them received dialysis, half of them didn't. As you can see, the number of patients with acute kidney injury, when we go higher in the stages of SCAI, continues to increase to the point that stage D and E, they almost have half of them have moderate to severe acute kidney injury versus stage A that only less than 5% have it. This is a 3D depiction of SCAI stages, acute kidney injury, and mortality. As you can see, stage A, B, C, mortality increases with development of acute kidney injury and progressive stage of heart failure. However, stage D and E, as you can see, a lot of patients do not have acute kidney injury in these two stages. The reason is not because they are healthier and kidney is resistant, because they die before they can have acute kidney injury. This is competing risks for them. We also tried to compare this with sepsis. We identified 3,000 patients in medical ICU with diagnosis of septic shock. As you can see, sepsis and septic shock, as you can see, distribution of these patients in SCAI category. And what we found was exactly the same thing. This classification is able to predict mortality. When we go higher in the stages of SCAI, we see higher stage mortality rate as well. Even in adjusted mortality, stage D and E are associated with significant increase in mortality among these two patient populations. So to summarize, we need to recognize shock and identify its classes. We need to use clinical imaging and laboratory biomarkers. A new definition of refractory shock is necessary in order to harmonize what we talk about. And also SCAI as a case example of this could be potentially used as a template for what we can potentially use. I would like to acknowledge Dr. Ashish Khanna, who was supposed to deliver this talk, unfortunately wasn't able to, but share with me some data, and also my colleagues at Mayo, Dr. Jenser, Patkins, and Mukhtar. With that, I thank you for it.